watching this evening, 3.5 weeks after the interview occurred, a considerable part of the interview, some 30 minutes or so, up to the point where I introduced the word rabbit into the interview, and then resuming the last, to listen to the last several minutes of the interview, beginning with the portion where she said, "How do you want me to get in it?" And I told her that my thought was that I wanted her to take off all her clothes and run about the room. My thoughts about the interview, of course, are all interlarded with some thoughts I've had about it subsequently during these intervening 3.5 weeks. I want to mention a little about my set prior to this interview. I felt a considerable strain on my sense of professional identity. I've been a member of the American Psychoanalytic Association for nearly 20 years, and it is an important affiliation to me. But I felt considerably threatened in my affiliation with the American by reason of this 2-day conference I was to take part in. I had the feeling, and I still believe it to be a very sound one, that very few analysts of any repute at all would do such an interview. They would think it too antithetical to what psychoanalysis is ordinarily thought of as standing for, notably including anonymity, for example, that it simply was not a conservative thing for a psychoanalyst to be doing. About a week before the interview occurred, I learned that, so I was given to understand, or so I construed it, that each of the patients to be interviewed at the conference was an actor. With that, I felt that the thing would prove to be a farce. I thought that was the last straw, with the audience present, and then on top of it, for them to be actors. Then when I got to the conference and was told a few words about this patient, namely that she is a young woman in her 20s and that she is in psychotherapy, and also that I was given a slip with her name on it, and I was told not to look at this slip of paper, not to ascertain her name until after the interview had occurred. I found myself exasperated with the patient before I ever saw her on that account. I reacted to it as a neurotic controlling device that annoyed me. I did not, however, look at the name on the slip of paper until after the interview. The name is a very unusual one, and it is regrettable that we are simply not, for understandable reasons, at liberty to mention the young woman's name. Earlier in the day, I had seen the other two therapists interview and had felt that one, what I would call deficiency in their approach, was a notable lack of any kind of approach to what I would call negative transference. And one of the things I pride myself upon is what I believe to be my ability to work with negative transference, so that I felt sure that developments of that sort would occur in the interview. Another factor that day was that one of the previous interviews was with what I would call an ambulatory schizophrenic man who made an enormous impact upon the audience with his barely controlled rage. And I had a disturbed dream, clearly having to do with that patient, the night following those interviews, including the one I had with my patient. A dream which showed me that I had found that interview more disturbing, the one that occurred between another therapist and that man, more disturbing than I thought. And I had the notion that I was, without realizing it, competing with that patient as to who would have the more formidable audience effect. Now, all that notwithstanding, I regard this interview as a very typical one among those I have had with patients and before other audiences. To begin with, I made several notes watching these portions of the interview. When I put on this microphone around her neck, this was a familiar procedure to me, one that I felt good about being able to do, and it kind of helped me to feel reasonably comfortable in starting off the interview, and perhaps helping her to feel comfortable. I had to turn my back to the audience, as one can see, in doing that. And the role of the audience throughout the interview, I'm sure, was a very important one, and more important in more ways than I want to think it was. I feel sure of that. As the years have gone on, I more and more get some realizations of what a rich and how many ramifications the audience function is in such interviews. Now, when I asked her at the beginning to tell me whatever she found occurring to her throughout the interview, except insofar as I would be interrupting her, this was a more explicit direction than I usually give to patients. I usually leave them more on their own than that, really. When she said that her heart is beating, I did hear that as containing an underlying meaning of her finding reassurance that she is alive. And I was repeatedly in the interview responding to what I felt to be nuances in her tone, as well as her facial expression, posture, and so on. This about disembodied hand, I felt, was a very important development early in the interview that, as I understood it, gave a glimpse of very early childhood experience before other persons had become whole and differentiated persons in her experience of them, and presumably before her own body image had become complete. Something that questioning following the interview brought to my attention, and that I had not realized in the interview, was that various of the data that came forth suggested the violence in the mother of her early childhood, as a very important etiologic factor in her neurotic, or as I thought of them, schizoid difficulties. And my blind spot in that regard clearly links up with my own past, in which my own frightened or terrified experiences in early childhood in relation to a rageful mother have never been sufficiently explored for me to feel in good contact with that area of myself. I explained to this young woman, much more than I have to a lot of patients I've interviewed, why I was responding as I do. For instance, I would explain to her that your tone implies, I would say to her, such and such. I would let her know something more of what I was basing my intuitions upon. Whether that was because of my sensing the tension in her with the size of the audience, I don't know. Just why I was going farther out of my way to meet her dependent needs. I spoke to her of what I felt to be her struggle to have the whole stage to herself. And this, I thought, a repetitive theme in the interview, that she was, I felt unconsciously, very much defending against our being there together for the reason that would, for her, be experienced as a chaos in which we would not be two whole and separate individuals, but that it would be thoroughly confusing and chaotic. Hence I felt to be clearly her striving to have the whole stage to herself, or equally often to leave the whole stage to me while she watched from way back in the bleachers my trying to accomplish something without her help. Now, I have perhaps another 5 minutes, huh? Yes. When she said my name isn't necessarily my identity, and then I admired her nicety of differentiation there, her nice distinction that she was making, and I noticed on the tape how I look admiringly at her at that point. when I said to her, "You are wanting to hang me with that loop?" And she said, "Either you or me." On watching the tape of the interview, I felt something I had not during the interview, namely that she was thus expressing her disappointment with the interview. So I felt, viewing the tape, her bitter disappointment thus far with the interview, such that she didn't know whether she wanted to hang either one of us. She was so disappointed in both of us. When I said to her, "You're about as close to me as you get to most people," I asked her in a semi-questioning way. This, again, was one of my surest impressions about her in the interview, namely her repeatedly returning to for the most part maintaining a degree of psychological distance that was very much in keeping with the physical relative distance between us and all these obstacles between us. And it is that quality in her that I felt most clearly manifests her schizoid personality structure. That was certainly one of the main bodies of data. Repeatedly, I felt that I was admiring her complexity at times when she was being complex. Even though she was in a sense being difficult, I admired her that she was capable of being something more than the simple-minded, very conventional kind of young woman she, for the most part, was presenting herself as. I felt exasperated with her behaving as though she had never heard such words as clamber or cherish. And here is where I felt I was underestimating the degree of her psychopathology during the interview itself. On viewing the tape, I had the distinct impression that certain words, such as those, she probably attaches such idiosyncratic, or you might say autistic, meanings to, that she was unsure of what meaning I intended by them. The applause of the audience, I am used to this kind of thing in these interviews, and one of the things that I, again, pride myself on is my ability to foster humorous interaction, which often does evoke laughter from the audience. On the other hand, it also had a jarring effect on me repeatedly. It was, for me, uncomfortably highlighting the kind of showman aspect of the interview. And there certainly was an obvious competition between the girl and me as to who would be better able to touch the audience and evoke a response from them. She said a lot of books, she said, I've read on schizophrenia where they say they're not sure they're here, or they're not sure that whether they exist or not. Again, in watching the tape, I had the impression that she has been more concerned as to whether she is schizophrenic than I realized in the interview itself. One reason why I might bend over backward to play down the schizophrenia, although I don't think I usually do, is because I feel so well known for being a specialist in that field, and very, very often finding it in many, many places where other people have not found evidence for it. And this is a case where I think I was underestimating the degree of her psychopathology to some extent. I felt in watching the tape that I was apparently sitting there looking admiringly at my creation, as though the admiring look on my face was very much as though I had created her. And the first time that struck me, watching the tape, she was saying then, within a few seconds, "My father smoked cigars." That is, it was very much as though I were the father who had created, supposedly single-handedly, this young woman. And I was admiring my creation, and I think in keeping with that, I was not wanting to see the flaws in my creation. That is, I was not wanting to see some of the more borderline schizophrenic, perhaps, or my more considered judgment would be pseudo-neurotic schizophrenia kind of aspects of her. I did repeatedly during the interview think of her as having a schizoid personality. I thought it was interesting right after I said this about wanting to get through this shit, and said it with unusual vehemence, that she was then saying that she feels more here now than she was before. I am pleased to accept that as a valid communication from her. Whether it is or not, I have no way of knowing, but it sounded genuine. Now, this is the kind of thing I missed in the interview. When she said, right now, when you ask me, a moment has already passed. Now, in the interview, I reacted to that as a kind of neurotic, controlling trickery, complexity and trickery. There, I think I was underestimating the degree of her ego, her impairment of ego functioning. I think, and it was there in watching the tape that the diagnosis of pseudoneurotic schizophrenia occurred to me. That is, I think this young woman probably does tend to have her experience so compartmentalized in each succeeding moment, or at least under particular stress. I would guess her ego functioning works that way, so that when a moment has gone past, she perhaps isn't in touch with it as well as normal people are. And I spoke of it as her playing tricks on me. I think there was something more, I was going to say ominous. I shouldn't use that word perhaps, but something more severe in the way of psychopathology being manifested there. Then in these last several minutes of the interview, the point where the reason that we have not watched the whole interview this evening is that we all here in this setting are under some pressure for time this evening and did not feel able to watch the whole thing. In the last few minutes, where I said to her about her mother, "She's screwing you," and the patient said, in a sense of the word, yes. Well, I wasn't prepared for that degree of strength in the patient. And I too quickly tried to bail her out of a difficulty she wasn't really in. I said to her, "That screws you up." That is, I was shying away from the sexual meaning of it. And she said yes, but more dubiously. And this was one of the times, and there were a number of other times, I thought, particularly when sexual matters were being discussed, that the patient seemed, my thought is, readier for action than I was. I was hiding behind this therapist kind of role, I guess, and I had bitten off more than I can chew. More than I could chew is another thought I have about it. She wasn't shying away from sexual meanings much at all in that interview. I thought one thing of interest is that in my watching so much of the interview this evening, I was struck by how time and time again, my feeling was that that's the response I would make if I had it to do over again. That is, I kept hearing each time very much the same kind of intonations in her voice, for instance, that had impelled me to make the response I made during the interview. This about frog, I did think during the interview of a frog as a prince in disguise, but I thought it amusing that the idea of a kiss never occurred to me, that this is how the prince became once again a prince in the fairy tales. That is, there must have been something in the realm of kissing that in that interview that I was threatened by. Now, her wanting a drag from my cigar before she went, that very much got to me in the interview, and it got to me, as so to speak, in watching the interview. A poignancy of it, so I felt. I identified, I guess, very much with her. I suppose I was projecting upon her my own, much of my own dependent feelings. That kind of thing with other patients I've seen so very often is a vehicle for their sadism toward the doctor. They're making him feel that he is being cruel and depriving, ungiving, withholding. that in this instance I didn't feel comfortable to give her a drag on my cigar, and I don't think I should have in retrospect. But this I found a difficult moment when she said that. Now, when I saw the end of the tape, I felt a bit submergedly tearful, less so than I might have thought I would feel, really, and before this evening came along. Now, I'd appreciate any questions or comments that any of you gentlemen care to make.
Yes, one thing I noticed is that you seem to, most of the time, lead the interview. Whereas classically in analysis, we think of the patient leading the interview and the analyst making interpretations or comments or confrontations. But with only one or two exceptions, you initiated most of what happened. I wonder if that's the way you would characteristically see your analytic work in your office, or if it was different being in front of a professional audience, or what you see as the meaning of your stance that would be different from the traditional one there.
Yeah, I would think of it as very, very different in this interview from my characteristic way of doing psychoanalysis, certainly after the first few analytic interviews have occurred. In most of my psychoanalytic interviews, I say very little indeed. Many of them, I say nothing beyond an initial greeting and an initial indicating that the time is up. In an initial psychoanalytic interview, I might be, I am a good deal more active than that in inquiring about various things. But in this setting of interviewing a patient in front of an audience, I acknowledgedly am under a good deal of pressure to have something occur. It shows up most frequently in interviews where the patient tends to be very prominently silent. It is a difficult thing for me, and I have had the distinct impression that it is a difficult thing for the audience to let prolonged silences ensue. A really quite marked degree of tension occurs in the room, and I would have to be on much more close, comfortable terms with the audience than I felt with this one. If I were one of a rather small group of people and I were one interviewing the patient, a silence of 10, 15 minutes might occur without my necessarily feeling derelict toward the audience, for instance. But I do feel under pressure from the audience for something to occur, something tangible, and for words to be said, best of all for areas of the patient's functioning to be brought to light that had not been brought to light before in her treatment. Really, that's one of the things I'm aiming to do.
Did you feel that the patient used the audience in some way against you?
I certainly felt that with her saying that, frankly, she didn't think I knew what I was doing, and occasionally making derisive comments like that and evoking the audience's laughter, I surely felt that she was. That is a very familiar experience to me. I've very often had that. Do you want to add something there, I wonder?
Well, in relation to that, one of your goals was to focus on the negative transference.
Mm-hmm.
And I was wondering how the focus on the negative transference affects your facility in responding to her.
Affects my facility?
Yeah, in responding to her when she does leave an opening for you.
Are you still referring to her at times using the audience against me?
Yeah, using the audience, or other times when you're focused on the negative transference. Other times when maybe she did have some openings for you to...
to bring her negative transference to her attention?
Well, I was referring really more to responding positively to her and picking up some of her strengths, as you commented in your...
Yeah. Well, I don't think that this is the kind of thing you'd necessarily intend there, but what it makes me think of is to why didn't I bring before her using the audience against me. That's at least one thought I have about it. And I think that perhaps I was afraid of her actress ability. That she's a professional in that realm. And I'm sure in retrospect, and I think that it occurred to me in the interview, that there was a competing between us on this actor or actress level, too. And I think there we get into my not feeling on secure grounds with the audience. I think I felt that they were probably all too likely to laugh at me and to enjoy seeing me put down, you know.
Dr. Searles,
Dr. Fasagi.
With reference to the interview, what is it in terms of technique that you really wanted to convey to the audience?
I wanted them to get one message, at least, that all of one's thoughts and feelings and fantasies that one finds oneself having in the course of an interview with a patient are very likely to be utilizable as relevant data, relevant to what's going on in the patient. Reflections of feelings in the patient that the patient is unconsciously defended against experiencing, for example. And that I think that so many therapists are so quick to assume that their more private thoughts and feelings are sick or are unwanted intrusions into the work. And one of my strongest convictions is that our most private feelings are very frequently the most valuable data we have in terms of trying to divine what is occurring between the patient and ourselves. That's one thing. Now, in much that same spirit, I wanted the audience to come to realize that their more unpleasant feelings can be much more freely brought into the work with patients than they usually tend to bring them. And this effort of mine had in part to do with the two interviews that had occurred earlier in the day, in which my impression was that the therapists were very much functioning in a spirit of kindly, well-meaning, well-intentioned, intendedly helpful persons who had very little taste for being reacted to as frightening, hateful, whatnot. And in psychoanalytic terms, I regard psychoanalysis at its most essential as the analysis of the transference. And as examples of that, the patient carries over to the analyst all kinds of feelings which the patient was unconscious of having toward particularly parental figures in early childhood. And such transferences so very frequently are transferences from parents that were unconsciously regarded as very frightening, very stern, ungiving, cruel, and with schizophrenic patients in particular, the patient tends to react to the therapist as being something other than human, monstrous or totally lacking in feeling or whatnot. And for the patient to be helped to become free of their illness, the analyst needs to be able to work with feelings of that order toward him. And I don't mean that he should seek to be reacted to as monstrous, for example. But I mean that most therapists are readiest to help patients in ways in which the therapist can enjoy being regarded as kindly, helpful, and so on, and staying a million miles away from the patient's need to perceive him as hateful, terrifying, and so on. And yet, if the patient is ever to get free of her own most terrifying internal contents, she needs help with that kind of feelings.
Could I follow that up with a question in terms of the use of your own unconscious fantasies? Do you tend to use your fantasies in the way that you did in this interview, namely sharing them with the patient that you have in mind, or do you use it for your own data about the patient?
I share I would say, very small percentage of the fantasies I have about patients. The question of whether to share them with the patient depends on a multitude of factors, particularly the trying them out and seeing what the patient does with them is one thing. This patient was gratifying to me in many ways, in that she made, I thought, relatively good use of most of the fantasies I reported to her. Much more ill patients will very typically react to me as being crazy, and that these fantasies are a million miles out in left field. They have nothing to do with what's going on in the patient. And the more ill the patient is, it's a truism in my experience anyway, the readier they are to see the other person as crazy, the other person such as the doctor interviewing them. If on reporting a fantasy to a patient, I get evidence that this does not but increase the patient's anxiety, there's obviously no point in reporting fantasies as yet. Another limiting factor is how much the therapist can stand of feeling isolated. I mean, if the patient provides no corroboration at all for the relevancy of the therapist's fantasy, the therapist feels very, very much alone, feels threatened with being regarded as crazy, and they usually retire to a more conventional stance. The more collaborative a patient is, the more free I feel to mention to them a fantasy I've had. Another thing, it makes a great difference whether you report the fantasy to the patient in a spirit of sharing this as part of the collaborative work, while giving the patient to understand that you're quite prepared to maintain, if need be, the full responsibility for the fantasy. A big difference as compared to a guilty confessional kind of thing to the patient, which tends to make the patient feel burdened. Yes?
I wonder, with this particular patient, what you consider to be or would be the major issues if you were to continue working with this patient and leave treatment? Mm-hmm. What major themes, problems there would be in your work with her, and what the prognosis would be?
What some of the major issues would be, I would think that I would find that these Weller aspects of her, these aspects of her that led me to say that I feel that to tell her that it seems to me in so very many ways she's a very well person, a healthy person, that I would guess within a relatively few months' time, that I would see those aspects of her as being more and more superficial, really. And I would probably get more and more conscious of her schizoid personality, which is for the most part being hidden behind a facade of conventional social skills that have a seeming interpersonal closeness in them. I also feel sure, find much data indicative of fear on her part of violence. This is what I described as chaotic confusion kind of violence. And violence not only on the other person's part, but of course on her own part, and with there being sufficient of a mix-up so that one wouldn't know, one wouldn't have any subject and any object really in her experience of it. Now, I would think we would get a lot of data linking this up to her early experience with her mother. We saw evidence in the interview that the mother's possessiveness of the father largely barred him from her in some ways. And I had the impression in the interview that the father and the mother were so bound up that the mother was pretty darn much available to this girl. I would assume in the light of the unfolding transference to me that I would be reacted to as barred from her, reacted to by her, and that she would more and more actively seek and want and yet also fear closeness. Without an audience present, without the need for something to be happening to keep the audience interested, I'm sure that I would be much less verbally interactive with her. I would leave silences more in her hands to break as she became able to. As to her prognosis, I think she has a relatively good prognosis, but I think the girl could well use years of treatment. That is, I don't think that her difficulty is so mild that in a year's time, for instance, we would see a very marked change in her ego structure. I think that anyone with that much of a schizoid ego functioning, I think would require a number of years of treatment. But I think she's a sufficiently gratifying patient to work with so that the years would be well spent for the therapist as well as herself. Yes, Dr. Grayson?
Yes, I was just thinking unless you have further comments, we may just stop at that point. Further comments that you have?
Yes, I wanted to add this postscript to the interview. I was out in the hall in the hotel at the end of the afternoon's proceedings, and no, it was about half an hour after the interview, I guess, some break occurred. And this young woman came up to me, this patient, and said, I just wanted to have a chance to say goodbye to you, I think she put it. It was a very friendly, it felt to me very intimate, pleasant thing, and I put my arm around her very easily and naturally, but then immediately found myself hoping that a great many people would see this kind of vindication of our tender relationship. So I felt a real affectional bond had developed between her and me. I think it worth mentioning, too, that I have a daughter who's 23 years old and who is an actress, and I'm sure there's a lot of carryover of feeling, both positive as well as negative, to this girl from my daughter. Thank you very much.
Thank you.
Thank you.
Searles.